This next session, Behind the Scenes of a Brain Tumor Board, you will listen in as a multidisciplinary panel of expert clinicians simulate the review of brain tumor cases to determine the best course of treatment for patients. This session really shows you how complicated care decisions can be, and it's not a clear-cut answer. Serving as our panel facilitator in this year's Joel A. Gingras Jr. awardee that you just heard from moments ago will be Dr. Mark Gilbert. Please welcome Dr. Gilbert, who will introduce each of our panelists.
Great. Thank you so much, Emily, and thank you everybody for joining us this morning. It is a bit early, but as Emily said, a fantastic opportunity to expand discussion and to make sure that we can answer as many questions as possible. So I'm sure almost everybody has heard about a tumor board. This is a really important multidisciplinary effort to really optimize the care of patients. And of course, in cancer, in the various types of cancers, tumor boards happen all the time at major medical centers. So what we're going to do is to sort of give you a behind the scenes look at a brain tumor board. And we're very fortunate to have an outstanding panel. So joining in today's tumor board, one of the co-leaders of this year's ABTA meeting is Nancy Ann Oberheim Bush, who's a neuro-oncologist at the University of California in San Francisco. Dr. Mahua Day, who's a neurosurgeon at the University of Wisconsin in Madison. Our radiation oncologist is the other co-leader of this year's meeting, Vinai Gondi, who's a radiation oncologist at Northwestern Medicine Proton Center. And our neuropathologist is Dr. Craig Horbinski, who's at Northwestern University. So I'd like to start by thanking them for participating in this year's sort of behind the scenes tumor board. Let me go to the next slide. Go back. These are disclosures from our panel. But again, what are the objectives? It's really so to give the participants in the conference an idea of how behind the scenes we make very, very important decisions. It's a true collaborative effort. As you can see by the panel, it is multidisciplinary, and it is the discussion of individual patients. We want to go through, we will go through 2 patient examples and show you how each of our experts contributes and how there is actual discussion. And then most often a consensus is determined, and then that is the recommendation that is put forth to the patient's treating physician, and then discussion with patient and family. So you will, in fact, hear different perspectives on these various cases. So we're going to start with our first case. This is a patient, a 35-year-old right-handed man who developed headaches and left-sided weakness over several weeks. And just to give everybody a little bit of background, we're looking at magnetic resonance imaging, or MRI. These are axial cuts through the MRI. So we're going through the head in this dimension, just to give people orientation. By convention, it is as if we are looking at the person. So the right side is to your left. And in this case, we can see a tumor on both the axial T1 post-contrast, and the other scan on the right is an axial T2 flare. So the axial, the T1, it gives us great anatomical visualization. And in that scan, very little is bright except for fat, blood. And so when we give intravenous contrast, that comes up as white, and you can see that enhancement. The T2 flare is very sensitive to any alteration in the brain parenchyma, and therefore, when we see abnormal water, as we see with the swelling associated on the right, that T2 flare is quite sensitive to that. So just a very quick orientation. And so I'm going to ask Dr. Day, who is a neurosurgeon and quite experienced with evaluating MRI, to give her her opinion on what is seen on this scan.
Thanks, Dr. Gilbert. So as you described the scan very thoroughly, it is a right-sided lesion. It's centered in the frontoparietal area, very close to where the motor fibers would be running down. I would assume, based on the scan, that the patient has some kind of left-sided weakness, which is already on the slide. And based on the amount of edema, a lot of the weakness may be because of the actual, not the tumor, but the edema that's surrounding that. So, you know, this lesion is definitely resectable, that we can take out. And I would think with proper mapping, taking this out, the weakness should improve, since the edema will go down once the tumor is resected.
Thank you. And so as we find out, the patient underwent a biopsy, so just a small sample at a community hospital. And the pathology, as we'll talk about in greater detail, was concerning for a high-grade glioma. He then developed a worsening headache, vomiting, left-sided weakness, and transferred to an academic medical center, and then underwent a surgical gross total resection. So I'll call on Dr. Day again and ask, you know, about this scenario and you know, your thoughts about biopsy versus resection, and what goes into determining approach, and what type of message and what should patients and their families think about in the context of having a diagnosis of a mass. Again, we don't know what it is when we're just looking at MRI, but what are the thoughts that and considerations that you have when looking at a situation like this?
So the first thing is safety. It's how comfortable the surgeon is thinking about the lesion. So getting a diagnosis, tissue is always the first step. So in a community hospital, getting a biopsy is reasonable if the surgical team is not comfortable with going for a gross total resection, especially in a location as such like this, where we would do motor mapping while we are resecting the tumor. And a lot of time that's not available in a community hospital. So it is a reasonable step where you get a biopsy, and based on the diagnosis, most of the time, all the literature thus far would show surgical resection does benefit, the extent of resection does matter. But most of the time we're limited by the eloquence of the brain, because our job is to straddle the two sides. Once we want to take out as much tumor as we can, on the other side, we want to maintain the overall functional outcome of the patient, because that plays a significant role in further treatment that's needed for most of these tumors. So in a big academic center, the way I would approach it is with motor mapping. We will you know, get imaging of the motor fibers that are going around it, which are called like DTI imaging, to orient myself how the fibers are tracking. And during surgery, I will have continuous motor mapping to guide me to push for gross total resection.
Great, thank you so much. And I'm going to turn now to Dr. Horbinski. So from a neuropathologist perspective, tell us your thoughts, if you would, about the difference between receiving a biopsy versus receiving a massive tumor that has been removed, as in this case. So what are the implications?
biopsy material, of course, is smaller, so there's always the chance that histologically it will not represent the full scope of the pathology that's in the patient. There's always that sampling risk, whereas if you have a larger resection specimen, the odds of getting representative tissue go up. That said, these days with molecular diagnostics, we are able to do more and extract more information out of smaller and smaller pieces of tissue than ever before.
Great, thank you. And Dr. Gondi, again, I will be calling on you for your radiation therapy expertise, but your perspectives on the radiation treatment in a situation with just a biopsy and large amount of residual tumor versus a situation like this where we've got a very good tumor resection?
Yeah, it's a good question. I think one of the concerns that we have with radiotherapy is the potential that it causes an inflammatory response as it creates tumor cells to die. And as the tumor cells are dying, they're inflamed, and that creates more edema, and that has the potential to do two things. One, make a patient's presenting neurologic deficits worse, and two, require them to be on steroids much longer than they are, which in itself could also make the patient's quality of life and neurologic issues even worse. So from our perspective, it is helpful to have as much of the most active component of this tumor that's causing the neurologic issues and causing the swelling removed by skillful surgeons like Dr. Day.
Great, thank you. And finally, Dr. Bush, let's change this scenario a little bit just for the sake of discussion, and imagine a patient like this came to you but was not actually neurologically worse. You do have a biopsy specimen. What are your thought processes about deciding to proceed on as the neuro-oncologist with the primary treatment, or considering to actually have the patient go to the operating room to undergo an extensive resection like has happened? Again, patient's not symptomatic as this patient was, but asymptomatic in your office. How do you make that decision?
That's a great question. We heard yesterday some really compelling evidence from Dr. Harvey Jumper talking about how extensive resection really matters. And especially for both actually the low and the high grade patients, the more tumor you can resect, the better overall prognosis. So in general, if the surgery can be done safely, we would recommend going back for a second look to remove the tumor tissue. In addition, something that an academic neuro-oncologist commonly thinks about is clinical trial eligibility. And in many cases, there are clinical trials that you might be eligible for if you have a surgery versus just a biopsy alone. And so I think there's a lot of things that come into consideration, but if someone is asymptomatic, we would push usually for a further resection. Something else to think about, if we're not going to do surgery and we're going to do just a biopsy, we may kind of rush to get that radiation and chemotherapy started, working with a radiation oncologist to really quickly start treatment.
Great, thank you so much. All right, so Dr. Horbinski, you now have the tumor in the pathology laboratory. Take us through what you do.
On the left is a traditional hematoxylin and eosin stained tissue section from that resection. And here we can see in the lower left field necrosis with palisading of tumor cells around the necrosis. And then the pinkish clusters in the upper right and mid right part of the field, that's all what we call microvascular proliferation. Those are exuberant blood vessels that are growing. That's just a single image. Elsewhere in the specimen at a higher power, we would see mitoses and an infiltrative pattern wherein the tumor cells are crawling or migrating through the brain parenchyma. So histologically, these histologic features are strongly suggestive of a glioblastoma, IDH wild type. Now, these days, we always try as much as possible to confirm the diagnosis with ancillary molecular testing. And in this case, by next-gen sequencing, we found out that it was indeed wild type, meaning a lacked the mutation for a gene called IDH1, which is a very important gene as concerns prognosis. It also has gain of chromosome 7 and loss of chromosome 10. Those are very common genomic aberrations in glioblastomas. It has TERT promoter mutation and EGFR amplification. So both by histology and by molecular profile, this is a classic, so to speak, a classic IDH wild type glioblastoma. Another thing we're doing now more recently is DNA methylation profiling, where we take essentially a genomic fingerprint of the tumor tissue, and that allows us to discriminate between otherwise very histologically similar types of tumors. And in this case, you'll see on that plot on the right, it's actually over 20,000 different dimensions of methylation data that have been artificially compressed into a two-dimensional format that we can appreciate. So all the different colored clusters you see on the right side are all different tumor entities. Like, for example, the red clusters are different kinds of ependymomas. The far right cluster is IDH mutant astrocytomas and oligodendrogliomas. The larger green cluster to the lower right of center are the different subtypes of IDH wild type glioblastomas. In this case in particular is indicated by the red asterisk clustered within one of those IDH wild type GBM subtypes. So this really adds multiple layers of information that confirm what we thought histologically, and that this is indeed an IDH wild type GBM.
Thank you. That's a fantastic explanation. So let me ask you the question, are all IDH wild type glioma glioblastoma?
No, that's where things get a little complicated. So there's a lot of gliomas out there that are IDH wild type, but don't have the same prognosis that an IDH wild type glioblastoma have. So you've got lower grade tumors that are driven predominantly by BRAF mutations or fusions. Those are going to be IDH wild type, but those are essentially low grade tumors. Medulloblastomas will be IDH wild type. Ependymomas will always be IDH wild type. So there's a lot of different kinds of tumors that are IDH wild type. That information by itself is not enough to call out an IDH wild type glioblastoma. There has to be additional histologic and molecular features that align with that diagnosis.
Great, thank you. And Dr. Bush, so what's the clinical significance? You have an IDH wild type glioblastoma, and you have a grade 4 IDH mutated glioma. So is there a difference?
So there certainly is a difference in prognosis. So the patients with the IDH wild type tumors have a worse prognosis than patients with IDH mutant tumors. However, at this moment in history, I think both of those patients would be treated with very similar treatment options with radiation and chemotherapy that we'll think about, but it does really make a difference in the patients for sure.
Great, thank you. And we'll, I think, move on. So again, here's the pathology report. And so Dr. Horbinski, this looks like a summarization of an integrated report. So do you want to talk a little bit about the evolution of pathology reports from being sort of classically based on what you see under the microscope to this integrated report where you have both the classic as well as the molecular findings?
For most of pathology's history, by the way, the traditional hematoxylin and eosin stain is over 100 years old, so we still use it. It goes to show how robust it is. But in most of that time, it was strictly based on what we saw under the microscope and what we thought the tumor was going to do based on its snapshot histologic appearance. And that still is a very critical part of the pathology report, but this additional molecular testing has to be taken into consideration as well. And most of the time, the histology and the molecular do align. In other words, like in this case, it looks like a classic IDH wild type GBM, and the molecular confirmed it. So that's fine. Then the integrated diagnosis, everything is in agreement. But there are cases where you think the tumor is one thing, maybe it looks like a lower grade tumor, and the molecular ends up indicating something more aggressive. And in that case, the integrated diagnosis would take into account that molecular data. And so in this case, when we issue these pathology diagnoses, it's not just what we see under the microscope anymore. It's that plus the molecular, which means the time it takes for us to issue that integrated diagnosis is a little longer. It's not just a day or two after the tumor was resected. That's just when we get our histologic impression of what's going on. To get that final layer of molecular data takes another week and a half to 2 weeks. So that integrated diagnosis, which is really the final word on that tumor, so to speak, that doesn't come for a couple of weeks until after the surgery.
Great, thank you. And for the folks watching, I'm sure they've often heard about the MIB. So can you just describe for everybody what the MIB1 means if they see it on their report?
MIB1 or Ki-67 that's showing or is providing a rough estimate of what proportion of tumor cells are in the cell cycle, meaning they're undergoing cell division. Normally in a mature, quiescent, normal, non-neoplastic brain, no cells are undergoing division, or very, 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 very few, way less than 1%. In a low-grade tumor, you might see 1 to 2% MIB1 cell division, possibly. In a higher grade tumor, MIB1 can be 10% or more. As concerns prognosis, it really doesn't affect prognosis a whole lot, other than if you thought something was low grade, for example, and you did a MIB1 stain and you saw 20 to 30% cells were positive, that's a red flag. It's like, wait a minute, maybe this isn't as low grade as I thought it was. But the reverse doesn't really hold. We already have so much molecular data to prove that this is indeed an IDH wild-type GBM. It really doesn't even matter in this context what the MIB1 proliferation index is.
Great, thank you. And Dr. Bush, we see something called MGMT methylated. And do you want to tell us what that means and how that impacts the thoughts about treatment and prognosis?
Sure. Dr. Horbinski may be better, but the way I explain it to patients is MGMT is a DNA repair gene, fixes broken DNA. Our chemotherapy works by breaking DNA. So when MGMT is active, it comes along and basically fixes the damage that the chemotherapy does. And so the chemotherapy is not as effective. MGMT is turned off or inactive in its methylated state. And so when it's methylated, MGMT is turned off, actually the chemotherapies work better for patients. And so if someone has something called MGMT methylation, in general, the chemotherapy works better and people have a better overall prognosis. Now, MGMT is tested very differently in different places. On this particular report, it looks like it's an index out of 17, which usually means there were probably 17 different methylation sites tested. And this patient had 15 of the 17 be positive. So this would be someone we would consider highly methylated.
Great, thank you. So now we'll actually turn to treatment, and I'm going to ask Dr. Gondi, since to this date, radiation remains the cornerstone of care of malignant brain tumors. So what would your treatment recommendations be? We have the treatments that were provided, but your thoughts and approach, again, in a 35-year-old person with a single tumor that's been resected.
Yeah, thanks, Mark. I think it's important to, as you mentioned, recognize that radiotherapy is one of the most effective treatments for this particular tumor, but it also can be one of the most harmful to patients. So finding the right balance in terms of trying to prolong survivorship of our patients while also preserving their quality of life. Very similar to the way Dr. Day mentioned her approach to surgical resection. As many of my patients know, I like to compare these tumors kind of like to an iceberg, in the sense that you have this piece of ice above the water that Dr. Day will try to resect as much of that ice above the water as she safely can. But we do know that there is ice below the water. And the goal of what we try to do with radiotherapy is to treat as much of the ice, both above the water and below the water, as possible. And that takes careful coordination and detailed planning in terms of the area of the brain that we're going to be treating, the water that is, and how much, to which dose do we want to treat. So related to the second factor, that's an open discussion that we have with our patients regarding goals of care. Certainly in a 35-year-old gentleman with an MGMT promoter methylated tumor, we anticipate a very reasonable survivorship, in part because Dr. Oberheim Bush mentioned, chemotherapy is also very effective in this particular tumor. And so within that respect, we would want to maximize their survivorship. And so we would do what we consider as conventional radiotherapy over 6 weeks to a dose of 60 gray. And we understand that that dose is actually contributing to their survivorship. In contrast, if we had a patient who was much older, or perhaps doing much more poorly as a result of their tumor or after surgery, we think about trying not to give too much radiation dose because we worry that that might cause become more harmful to them. But in this young gentleman, yes, we would offer them 6 weeks of radiotherapy. Now the dose tends to be split up into two components. The initial dose, typically treated to about 46 gray, is meant to treat the entirety of the piece of ice that we can anticipate, both what's above the water and what's below the water, based on our understanding of the MRI and our understanding of gliomatous infiltration or spread of that iceberg. And that's done in close collaboration with our neuroradiologist, as Dr. Cha mentioned yesterday in her presentation. But then the last 14 gray, or the last week and a half of treatment, we give a boost radiation dose to the area of the iceberg that we know is the most likely to resurface above the water. And that's the surgical bed where Dr. Day did her best to try to resect as much of that iceberg as possible. So that gets a higher radiation dose in an attempt to try to keep the ice below the water for as long as possible.
Great, thank you for that wonderful explanation. Dr. Oberheim Bush, we see temozolomide and we see tumor treating fields. So could you sort of take us through the plan and the thought process with that?
Absolutely. So temozolomide is an alkylating oral chemotherapy. Many of the people listening in may have had temozolomide. It's our standard of care for high-grade gliomas based on Roger Stoops' landmark trial showing that it had a benefit for patients with glioblastoma. You take it every single day during radiation. The radiation, you get weekends off. Chemo, you have to take every single day, 7 days a week. So you do that for 6 weeks. And then usually we give you a bit of a break to recover from the radiation because it makes you tired and the chemo is not necessarily fun when you're taking it every single day. And then after that break, we give more chemo. And that chemo is the same chemo pill, the Temodar, but we give it in a different way. It's usually double the dose, but you only have to take it 5 days in a row every month. So you take it 5 days in a row, the rest of the month off, no treatment. But we check your labs because the labs will go down on day 21 and they come back up on day 28. And those 28 days are called a cycle. And the goal is to do that 6 to 12 times or 6 to 12 cycles with MRI every 2 cycles. Something that we also consider adding after the radiation is over is called tumor treating fields from a company called Optune or Novacure. Totally different way of treating brain tumors. It's actually a device that you wear on your head. You have to shave your head. And you wear these electrodes on your head, 4 pads of them. And if you wear them 18 hours a day, every single day, not just the days that you're on chemo, studies have shown that it also provides an overall survival benefit for patients with glioblastoma. So it's definitely something that patients can add to their standard therapy after radiation is over if they'd like to.
Great, thank you so much. Okay, so the patient underwent the standard of care. And then develop worsening left-sided weakness. And I'm going to ask Dr. Day to serve as the neuroradiologist and take us through these scans.
So here we see axial scans, as you previously described very well, one with contrast and one flare. And in the resection bed now, we see some nodular enhancement anterior to the previous resection cavity. And that was the scan right after the finish of the radiation. And the one below is after 4 cycles of Temodar, which looks like that enhancing component is much bigger after 4 months compared to what we had right after the finish of the radiation. And if we look at the flare scan, we also see a lot of extra flare signaling 4 months after. So, you know, whenever we see this, there's always this debate about treatment effect versus recurrence. Things that to keep in mind whenever people have additional deficits, the tumor is growing on subsequent scans, increased flare signal. This all probably points more to a recurrence than true treatment effect, but it's a big debate in the field as to how we can really tell that without additional surgical resection. And if we look at the growth, it's primarily anteriorly, and it's going more into the motor cortex, which explains why the weakness is getting worse. So this is something, again, we would take to our tumor board for further discussion.
Okay, thank you. And Dr. Gondi, so I'm sure you've seen this scenario many times. You have somebody who's getting neurologically worse. The scan is worse. You know, what do you do? I mean, how do you immediately declare this progression? Do you continue to observe? What is your standard algorithm? This is such an important aspect in the care of patients with malignant brain tumors.
Yeah, I would say there are a number of principles. Number one, I think Dr. Day really hit on it, which is multidisciplinary collaboration, getting everybody together in a tumor board and discussing what's going on here and evaluating the patient. Number two, this is where I think it's important for radiation oncologists to continue to follow their patients for several months after they finish, because at the end of the day, we're the only ones who knows what's been treated with radiotherapy. So it becomes important to localize what the imaging changes are relative to the not only the area that's been treated with radiotherapy, but the dose to which has been treated. You know, Dr. Oberheim Bush mentioned those 3 treatments in terms of radiotherapy, temozolomide, tumor treating fields. I think what unifies all of those treatments is that the way they cause tumor cells to die is they do so at the time of what we call mitosis or cell division, which relates back to what Dr. Horbinski was speaking about with MIB1 or Ki67, that these are tumors that are rapidly trying to divide, and our treatments are meant to take advantage of that every time they try to divide, they cannot, so then they die. And what happens in these scenarios is as they're dying, they're creating this inflammatory response that we call pseudo-progression that has some classic imaging features, but also has some classic clinical features that we anticipate, the most important being steroid responsiveness. And so that becomes something that we also consider is the initiation of steroids, not necessarily to treat the image, but to treat the patient, and the fact that the patient now is developing some left-sided weakness related to where this process is occurring. And then lastly, if there is a continued concern, if the patient's not improving on steroids, then certainly we need to be very thoughtful about the possibility, as Dr. Day mentioned, that this is not pseudo-progression, meaning tumor cells dying, creating a lot of inflammation, but it's perhaps a scenario of tumor cells that have grown through what we've already administered, and therefore we need to think about salvage therapy options.
Great, thank you. So Dr. Day, let's say this is your patient. What would your next step be?
So re-resection in the setting for someone who is young, otherwise in reasonable health, is definitely an option. If the discussion in the tumor board, like Dr. Gondi says, is a consensus that's going towards that this is most likely a tumor recurrence and not a pseudo progression, then I would, offer a re-resection that we can safely do in this area without making the weakness worse.
Great, thank you. Yes, and so getting the entire panel's opinion. So Dr. Oberheim Bush, again, this is such a common scenario. your recommendation at this point? We have conventional imaging here.
Yeah, so one of the things that we learned about yesterday from Dr. Shaw is that, the bread and butter of neuro-oncology is axial T2 flare and post-contrast. However, to try to understand if something's tumor progression versus pseudo-progression, sometimes you have to look at the company it keeps with other kinds of imaging sequences. So if they're not available, maybe we'll ask for some more specialized imaging, such as DWI or perfusion imaging to help us. And she talked a little bit yesterday about SWI, like a blood product, which sometimes is associated with treatment effects. So this is perfect. Do you want me to comment on this? Is that okay,
Yes,
Dr.
please.
Gilbert, or do
Yep.
you want? Okay.
No.
And so here we're looking again at the T1 post-contrast and the T2 flare, which we looked at, but we're also looking at two other imaging sequences that either are routinely done at some institutions or could be done to help clarify the issue. One is cerebral blood volume, which is looking at the amount of blood that's going to a specific site. Now we know when things are treatment effects, it doesn't really light up with a lot of blood products. And on these scans, the more red it is, the more blood is there. So I'm not really seeing a ton of kind of elevated blood in that area. One thing to note, not only is it tumors that do light up, but if you're having seizures, you might also see an elevation in that sequence. And then the other one is called diffusion weighted imaging. And this is a little bit of a marker of cellularity. I tell patients this is how we see strokes. They're light bulb bright, and tumors can sometimes be a little bit of a hazy bright. And again, I'm not really seeing a ton of, when you localize it, if you put the little calipers that we can do with our fancy imaging right on top of each other, a ton of DWI. So if I'm looking at these images, I might say, maybe we should hold course for a little bit and not necessarily jump to surgery and kind of see how things evolve. And many times we say, hey, instead of 2 months, let's do a 1 month scan. Let's just keep a close eye on this. And then the other thing that we talk about, like Dr. Gondi said, is, if this is treatment effects and inflammation, there's 3 ways to make it go away. One is time, which is the slowest. The second is steroids, which are pretty good, but sometimes take a while to work and they have long-term side effects. And the third is every once in a while we use this stronger medicine called Bevacizumab or Avastin, which is a vascular endothelial growth factor receptor antibody, which plugs up leaky blood vessels and can kind of make radiation-induced swelling go away very quickly. So if someone is very symptomatic or having a lot of difficulty with steroids, that might be another option that we might discuss with a patient while we're trying to figure out if this is tumor or treatment effects.
Great, thank you. And so in fact, to move along, the patient was treated with bevacizumab, a single dose. So I think that's really remarkable. And so Dr. Oberheim Bush, if you would just sort of take us through what you see and what you would, how you would interpret this.
Sure. So it looks like we have the scan before they were given the bevacizumab, and then 1 month later, right after bevacizumab, just 1 dose. And you can see not only did the enhancement get better, but the T2 flare got better. And so this patient had a nice response where things kind of calmed down, which would argue more towards a treatment effect. If this was tumor, a lot of times we'll still see some things get better, the enhancement get better, but actually the mass-like flare gets worse because there's still underlying tumor there. And so in this case, though, it really looking like everything is looking better, which would argue that this was likely an impact of the treatment itself. And then one other thing to mention that I forgot that I was thinking about when you were talking is that sometimes we actually see these inflammatory reactions more commonly in patients that are highly MGMT methylated. And so that can also sometimes play into our decision, even thinking back to the original pathology about whether or not this may be treatment effects versus progression.
Right. I think that's an important point. And there are actually some studies that suggest patients who do develop pseudo-progression may actually do better than patients who have what looks like a response to the radiation and chemotherapy. So it's a bit paradoxical, right? So so again, looks like a great response, but let's change the scenario a little bit and let's imagine that the bevacizumab didn't work. All right, and we don't see this change. What would your, let me ask Dr. Day. So I'm the neuro-oncologist and I'm sort of at this crossroads. it may be pseudo-progression, but it may also be tumor. What are your thoughts? And you so eloquently described how it is growing into the motor region. I mean, so how does one think about the risk benefit of either removing it or sampling it to make a more definitive diagnosis?
So whenever we see a patient who has been exposed to bevacizumab, that just adds another layer of complication to the surgical planning, because Avastin does increase risk of postoperative hemorrhage. Although it closes blood-brain barrier, it does have a paradoxical effect of increasing risk of bleeding post-op. So that's something we always discuss in the tumor board and with the patient as the timing of the surgery. In terms of the exact location, it is growing anteriorly more towards the motor strip, but again, it is something that can be done safely with motor mapping. Depending on the patient and their tolerance, sometimes motor mapping we can do asleep pretty reliably. If it is someone who is a pianist or who really needs like a excellent control of their hands, we can even do this awake to have a better understanding of, or to preserve the function better. So, but if those options are not available in a smaller community hospital, then biopsy is a way to delineate between pseudo-progression versus tumor recurrence.
Great, thank you so much. So Dr. Horbinski, we're talking about tissue sampling. Your thoughts about the distinction between pseudo-progression and true progression?
Pseudo-progression histologically isn't really a pathologic diagnosis that we can issue. All we can say is, let's say the tumor or the tissue was resected, and we look at it under the microscope, and we see lots and lots of inflammation, necrosis, reactive gliosis, all these other sorts of things, but not actual tumor cells. That in that case, those are the histologic correlates really of pseudo-progression. So you would never see us issue the diagnosis pseudo-progression. We would just say, you know, reactive brain tissue with inflammation and so on and so forth. Although these days, in such a situation, we would always run it through next generation sequencing just to see if we can pick up the same pathologic mutations that we saw at the time of original diagnosis. Because if we do, that suggests that yes, there are tumor cells in the specimen. Now, it becomes a question of, were those residual tumor cells, meaning were they there all along, or were they cells that grew back after treatment? And that's a very, very difficult question to answer. We argue amongst ourselves all the time. My own personal litmus test is, if I see healthy looking tumor that's actively proliferating, I call that recurrent tumor. If I just see some tumor cells there that look like they're beaten up physically by the radiation and chemotherapy, they have really roughed up nuclei. Even if I see a few mutations by sequencing, I'm probably going to say, look, this is probably just residual tumor from the original treatment. It's not actively regrowing.
That's great, and I appreciate that terrific explanation, because when we do get the reports and communicate with our neuropathologists, it's sometimes, you know, it's not as clear cut, and I think it's important for everybody to understand that there are nuances, and I think you did a great job in explaining your approach, and I think your approach is probably very comparable to many of your colleagues. So thank you for that. All right, moving along. So the patient went on to complete the 6 cycles of the post-radiation temozolomide, as Dr. Oberheim Busch described, and for 2 years underwent surveillance until new imaging changes were seen. And so I'm going to call on our neuroradiologist du jour, Dr. Day, to guide us through.
So again, we are looking at the axial post and axial flare images. Between the 2 years, now we definitely see a more enhancing mass-like lesion that's creeping more anteriorly with pretty significant flare changes now. And some of it looks like it's traversing along the corpus callosum and even on the other side. So based on the imaging, this looks very suspicious for, again, probably tumor recurrence at this point.
Great, thank you. Yeah, and I think the important point is, it's 2 years, and that's kind of late for pseudo-progression. And there's also infiltration, as you pointed out, through that part of the brain called the corpus callosum to the other side of the brain. So here's the imaging. So Dr. Oberheim Bush, you did such a wonderful job with the advanced imaging before. If you can take us through again.
Sure. I think it's important to note here that you are seeing this kind of elevated in the red in that area that we're really worried about in the corpus callosum. And you're also starting to see a little bit more restricted diffusion with this like hazy gray in that area. And then the other thing that we do at the tumor board is I say, Dr. Gondi, did this get any radiation even? And I think probably the answer would be no, Nancy, and I did not radiate this part of the brain, which again would push us to say, okay, we're really worried about this one.
Great, thank you. And so a patient underwent a resection, and I think everybody can appreciate not all of the tumor was able to, or mass was able to be removed, but the pathology revealed that it was in fact recurrent cancer, recurrent glioblastoma. So Dr. Horbinski, there's the report. Do you want to just take us through it?
Well, in this case, what you'll see is a part A. Treatment effects, what we mean is it's histologic indication of radiation and chemotherapy. So it's widespread necrosis, a lot of DNA damage. We can see that under the microscope. And it indicates that the therapy had an effect. Of course, it's never 100% treatment effect throughout the entire tumor. Otherwise, we'd have a cure. But unfortunately, in a related piece of tissue, we see infiltrate, that's in part B, we see infiltrating neoplastic astrocytes, just like in part A. And in part C, the same thing. There's going to be scattered cells throughout that are tumor cells. And that's the problem with these tumors, is that they are actively infiltrating. When I describe it to patients or the families, I describe it as ants crawling through a computer. So from a distance, you may not really be able to fully appreciate just how many ants are in that computer's CPU unless you disassemble the whole thing and get it under the microscope. And that's what we're seeing. So even radiologically, when you look at that MRI and you see that central core of contrast enhancement and then that penumbra of shaded area, I guarantee you the tumor cells are in both. On a microscopic basis, they are on both sides of the hemisphere. They are in every single lobe of that brain, and they're probably on their way down to the brainstem as well. So in this case, the MRI just doesn't capture the full tumor burden in that brain, and that's what makes these tumors so difficult to treat.
Great, thank you. So I also wanted to point out that as you mentioned, there were 3 components to the pathologic material. And that if only component A had been sampled, let's say by a biopsy, with the 75% treatment effect necrosis, I think that would have brought in the concern you had before about how do you distinguish if this is active cancer versus treatment effect. So any thoughts about the sampling and how important in this case it was to get a fairly substantial amount of the abnormality out?
Yeah, parts A and B would probably be, if that's all we had to work with, we would say, all right, it's questionable whether or not it's residual versus recurrent. In part C, I don't have the histology here to show, but you can, when pathologists sign it out as residual recurrent glioblastoma, they're really talking about actively regrowing tumor. And for whatever it's worth, even though the residual / recurrent is the common parlance, I try to get off the fence. And so when I write these up, I will say either I think it's residual or I think it's recurrent. I try to avoid this, combining the terms. So in part C, it's pretty apparent just by the way that's phrased that there is actively regrowing tumor in that ultrasonic aspiration material.
Fantastic, thank you. And this material was also sent for molecular analysis. And so if you would be kind enough to sort of take us through.
It shows largely what we saw on the original. So we've got gain of chromosome 7. That's what trisomy means. So tri means 3. Gain of chromosome 7. So there's 3 copies of chromosome 7. There's loss of chromosome 10. Normally there's 2 copies of chromosome 10. So normally it's disomy, di meaning 2, but in this case monosomy means 1. So we have 3 copies of chromosome 7, 1 copy of chromosome 10, and for reasons that nobody fully understands, that's a classic feature of most glioblastomas. Homozygous deletion of the gene encoding CDKN2A and B, so it's all basically one gene. That encodes something called P16, which is a very important break on the cell cycle. And so when the tumor loses that break on the cell cycle, that allows it to proliferate and grow back a lot faster. So so-called homozygous deletion of CDKN2AB, that's what we would call it. And then third, just like we saw before at the original diagnosis, high-level EGFR amplification. So normally every single one of your cells in the body is going to have 2 copies of the EGFR gene, which is good because you need EGFR. This one's going to have 50 or 100 copies of EGFR in per cell. So it's really, really amplified, way more than it should be. And it's specifically the EGFR V3 variant, which just means it's constitutively turned on. So this is a tumor that's really relying heavily on the EGFR signaling pathway to drive its malignancy. And P10 is a classic, that's a powerful tumor suppressor gene. That frame shift mutation, that's what FS stands for. The frame shift mutation, that just basically means the P10 gene is completely buggered up. It's completely non-functional. And that tumor has lost both the P10 tumor suppressor as well as CDKN2A and B. So it's really revved up. And the TERT promoter mutation, as indicated before, that's the way that the tumor cells achieve more or less immortality. In other words, they'll just keep dividing and dividing and dividing, and they'll never burn out. You could take a tumor like that and culture it in the laboratory setting and just keep regrowing it, repassaging it indefinitely, and it'll never burn out as long as it has nutrients to work with.
Great, thank you. So Dr. Oberheim-Busch, you get this report back, you know that there is recurrent tumor, which you suspected before the operation. You have a very good resection of the enhancing tumor. Your treatment recommendation?
So I usually tell patients that when tumors regrow, we think about all the options again. Can we take it out with surgery? Is it time that we can do more radiation or localize outside of the prior radiation field? Do we want to go back on the same chemo? Do we change chemos? Do we think about clinical trials? So for this patient, he's young, excellent resection. If there was a clinical trial option available, I would certainly think about that for him. Sometimes there are clinical trials that are specific against your molecular alteration. So for patients with CDK inhibitors or EGFR amplification, sometimes there's specific trials for that. So that would be an excellent option if we can find one of those. And then the other thing is, he did really well, 2 years, post, and he's MGMT methylated. So it's not unreasonable to think about returning back onto Temodar. We could switch chemotherapies to something called CCNU, which is usually our second-line therapy. Sometimes we talk about Bevacizumab or Avastin. I probably would not add that at this point for him if he's doing well post-op. So I think there are potentially a lot of options, but if there was a clinical trial, that would be something that I would be very interested in promoting.
Fantastic, thank you. And Dr. Gondi, your thoughts about radiation again?
Yeah, just like Dr. Oberheim-Busch mentioned, it's tempting to think about what got him 2 years and wanting to reciprocate that to get him another 2 years. But we have to be very careful. And certainly from a radiotherapy perspective, assessing where the area of progression is relative to the area that was treated 2 years prior. And sometimes can be a very straightforward, like putting 2 pieces of a puzzle together. Here's the puzzle piece that was radiated before. Here's the puzzle piece where this new tumor has come out and it's just outside of it, or it got a lower radiation dose than the initial area. Some of that can be feasibly done with advanced techniques like proton therapy or other ways where we try to treat this other puzzle piece and ensure that we don't overlap with the prior puzzle piece. But sometimes when we look at it, it's perhaps the puzzle pieces are overlapping too much. And in that scenario, we recognize that when we do reirradiation, there is a risk of radiation necrosis or injury to the brain tissue from cumulative exposure of the brain tissue to radiation. And radiation necrosis is not just predicted by how much radiation dose is exposed to brain tissue, but also the time interval between radiation exposures. So in that respect, if I anticipate in reviewing this case that the puzzle pieces are overlapping too much, then it would be my bias to favor what Dr. Oberheim-Busch is suggesting. Let's buy some time, try a clinical trial, try another alkylating agent like temozolomide, which worked the first time, or CCNU. And at some point down the road, we may need to use reirradiation, but at that point, we'll have more time on our side to lower the risk of radiation injury.
Fantastic. Thank you all. That was a great discussion. We're going to move now to the second patient. This is a 42-year-old right-handed teacher who had progressive headaches and worsening memory while teaching classes. And Dr. Day, you've done such a wonderful job as our neuroradiologist. I would ask you now to not only talk about the imaging changes, but give a brief overview of the perspective of the coronal.
All right, so here we're looking at FLAIR images. Both the images are FLAIR, which is very good at showing us the water content, which is the pathological tissue always has higher water content than the normal tissue. One, we have an axial imaging, the other one we have coronal imaging. Like Dr. Gilbert says, axial imaging is when we're taking slices like this, coronal is when you're taking slices like this. And we see this bright area on the left side, predominantly in the temporal lobe. And when we look at the coronal, it's expanding the temporal lobe. If we look at the Sylvian fissure, which is here, which the counterpart is here, so it's kind of pushing the Sylvian fissure up. So it's an expansile lesion, what we would call this, which is highly suggestive of some kind of primary brain tumor. She is right-handed. This is a left-sided lesion, predominantly in the temporal lobe. Most people are left hemisphere dominant. And by that, what we mean is our speech and speech processing lives primarily on the left side. So for someone like her, it'll be very important to get a functional MRI, which is a MRI that's done while a neurologist is telling them to do various tasks in terms of like assessing their speech, like repetition, finding words, and based on which area of the brain is being involved in that task, it gets higher blood flow. As a result, we get these bright signals that tells us where various speech areas live in relationship to the lesion that we're seeing. And here it says Warrenville's region is in the posterior margin. Warrenville's region is a region that makes sense of the speech. When we hear something, our brain has to put together what we hear and make sense of it. And that's where the comprehension part of the speech lives. So it's very, very critical for anybody, a teacher for sure, to have that functional area preserved. So this is someone I would definitely offer an awake surgery, because Like I previously said, we can reliably monitor motor even when people are asleep. There is no good way of monitoring speech when people are asleep. So this is something that we will, counsel the patient very well as to what to expect during the surgery, kind of go through the process with them before they even show up to the OR as to what the process will look like. Involves a big team of neurologists, neuromonitoring people. So there are a lot of people who are there and they're asked to perform the similar kind of tasks that they did during functional MRI, but now intra-op, and we assess their speech and comprehension. And with that, we keep going until we reach a functional boundary where we start seeing some disturbances in various aspects of the speech.
Great, thank you. And in fact, the patient underwent an awake craniotomy with language mapping and a maximum safe subtotal resection. And again, they must have reached a point where they found that there would be loss, so they stopped the resection. And I think everybody can appreciate that there is some abnormality on both the front or the anterior part and posterior part of the tumor mass. So now the tissue gets sent to neuropathology, and Dr. Horbinski, please take us through.
All right, so here on the left side, what we see is a tumor whose nuclei, those are the little purple things, mostly look round. That's a soft sign, a suggestion that it may indeed be an oligodendroglioma rather than an astrocytoma. Astrocytomas, their tumor nuclei tend to be more irregular and angulated. These look round. The other thing is that the cytoplasm is normally pink. Here you see a lot of white. And the reason you're seeing a lot of white, and if you look very carefully, you can see sharp cell borders. The reason you're seeing a lot of white is because the cells are swelling up. They're getting fluid. It's edema. That's another word for it. So the cells are swelling up, and histologically, that just looks like empty space. So it's white. Those two features are strongly suggestive of an oligodendroglioma. Now, in the old days, we would just say oligodendroglioma and then grade it based on whether or not we saw a lot of mitotic activity and necrosis and that sort of thing. But now we can be more rigorous in how we define an oligodendroglioma. And we do it by the next-gen sequencing panels and other molecular tests that we use for the glioblastomas. And in this case, instead of showing gain of chromosome 7, loss of 10, and EGFR amplification and that sort of thing, it showed an IDH mutation, and it did show a TERT promoter mutation, just like the IDH wild-type glioblastoma had. But in addition to the IDH mutation and the TERT mutation, there's also gain of chromosomes 1p and, loss of chromosomes 1p and 19q. We call that 1p 19q co-deletion. The cytogenetics are a little complicated, but basically the chromosomes 1 and 19 are actually right next to each other in the normal cell. And this weird break happens where the chromosomes will fuse together, and then that fused chromosome disappears. And the bottom line is, although that concatenation of molecular events produces an oligodendroglioma, which is defined as having an IDH mutation and this co-deletion of 1p and 19q. To further drive home the point, as if further proof was needed, we ran it through the same kind of methylation profiling that we ran that IDH wild-type glioblastoma through. Only in this case, you'll see that red asterisk is not in that green cluster of GBM anymore. It's over in the far right with that golden yellow cluster, and that real bright yellow cluster you see to the far right. Those are the oligodendroglioma subsets of IDH mutant gliomas. So we've got multiple lines of evidence all pointing towards the exact same diagnosis, which of course raises our confidence that this is indeed the correct diagnosis.
Fantastic. So again, just to emphasize that it can look like an oligodendroglioma down the microscope, but the new criteria say you need to confirm it with molecular testing.
Yeah, in fact, what we're finding, it's interesting that you should mention that, because when we do our brain tumor registry annual census of the number of new diagnoses of each molecular tumor subtype per year in the United States, oligodendroglioma has dropped substantially over the last 20 years. And the reason for that is that in the old days, the tumor cells look kind of round. Okay, I think it's probably an oligodendroglioma. Well, how round do they have to be for it to be an oligodendroglioma? You show 10 neuropathologists and you're going to get 12 different answers. So now that we've got these objective molecular tests, it adds a layer of objectivity to the diagnosis that was previously missing. So as you might imagine, the number of cases that we have now had dropped. It's not that the real incidence of oligodendroglioma has dropped. It's just that, you know, we're more precise in what we call an oligodendroglioma.
Great, thank you. All right, so I'm going to now turn it to our radiation oncologist and our neuro-oncologist and ask them. I'm going to start with Dr. Oberheim Busch and say, you're a patient. You've got a young person with good resection, but certainly not a completely resected grade 3 oligodendroglioma. Your treatment recommendation?
I would have to say a grade 3 oligo may be the most debated treatment management in our particular tumor boards. So I'm just going to start with that. So there really is potentially no right answer. And then just to hark back on something that we talked a lot about yesterday, a lot of the recommendations are dependent on your communication with your patient and what is important to your patient in their life. Because I can say, you know, all sorts of things, but it really comes down to having a discussion with the patient, what they want. But it could be observation. Probably I would not recommend observation in this particular case because there's a pretty substantial tumor burden left behind in language cortex. So that would make me very nervous just to watch. You could do radiation. There are definitely people that would say maybe you should try chemotherapy by itself. And then there are people who would do radiation then chemotherapy, people that would do radiation and chemotherapy. And there's also the question of temozolomide versus a different chemotherapy regimen called PCV. So there are multiple different options. If this was my patient, I think with a grade 3 oligo and language cortex, I personally would be recommending radiation and temozolomide, but that will not be the answer from everyone.
Great. Okay. And again, I think highlight the point that there are some wonderful studies that showed that the combination of chemotherapy and radiation is superior to radiation alone. But there's also, now that we have a refined diagnosis of oligodendroglioma, you know, I think we're rethinking some of the things, particularly in the context, as you mentioned, Dr. Oberheim Busch, when a tumor is completely resected. So this is a perfect opportunity for tumor boards to weigh in and for the treating physician to get opinions of colleagues and then to communicate with the patient, as you mentioned. So that does bring up the radiation question. So Dr. Gondi, if Dr. Oberheim Busch sends the patient to you and says, would you please do radiation? I'm either going to combine it with chemotherapy or I'm going to do chemotherapy afterwards. What are your thoughts about the radiation? What type of radiation? Are there things you consider, particularly in a person who has a disease which is one of the most treatable amongst the malignant glioma?
Yeah, no, thanks. A couple of principles that I would mention to build off of what Dr. Oberheim Busch mentioned. Number one, it's important to recognize the patients and caregivers recognize that they have time to figure out what they want to do. Speak to multiple different providers. Go see another radiation oncologist. I'm happy to provide referrals to friends of mine across the country because it's really important to get as much information and education about the goals of care and the different treatments that are available, as Dr. Oberheim Busch mentioned. So there's no rush in terms of what they decide to do. One of the things on these treatment recommendations that I probably would suggest to my patients, as you mentioned, Dr. Gilbert, is I would not recommend radiotherapy alone. And it's just my bias, and that's simply because we do have evidence that adding chemotherapy to radiotherapy does meaningfully prolong survivorship. To Dr. Oberheim Busch's point, I too would favor radiotherapy and chemotherapy, what I would consider combined modality therapy. Because of all the trials that we've done and all the published evidence, the longest survivorship data that we have, the longest survivorship timeline is when we do both now. And so that, I think, is an important consideration for patients as they think about what they want to do. But when we think about survivorship for someone who has a grade 3 1p19q co-deleted oligodendroglioma, glioma, and we're going to treat them with combined modality therapy, we're thinking of survivorship on the order of decades. And so from a perspective of a radiation oncologist, I have to be very thoughtful right now. If we're going to use radiotherapy, how do I do so safely? Not just for the first 6 weeks of radiotherapy or for the first 6 months after they finish, but I'm thinking about them for the decades of their survivorship. And so how do we ensure that we can do this as safely as we can? Very similar to how Dr. Day and her surgical colleagues would consider trying to do surgery but not impairing the person's speech. And so there are 3 things that I think about from that perspective. Number one, as many of my patients know, I like to get a high quality MRI of what I call a thin slice volumetric flare MRI that we saw in the last image. Oftentimes, conventional MRIs that are done in a lot of centers do not include that 3-dimensional volumetric flare. But that is super critical, not just for neurosurgical planning, but for radiotherapy planning, for understanding what this, to use my analogy before, what this iceberg looks like, both above the water and below the water. Related to that, though, is understanding which area of the brain I'm going to treat based on what I see on that MRI and my anticipation of gliomatous infiltration at this time. The second consideration is radiotherapy dose. The higher the radiotherapy dose, the higher the risk that we can cause injury to the brain tissue. And specifically, these effects can happen many years to decades down the road. We have a number of trials that have looked at whether there's any benefit to escalating radiation dose in these, what we consider lower grade gliomas. And both trials have showed no meaningful benefit. So with that respect, I typically, and this is just my bias, I tend to treat it to a very modest dose of radiotherapy. Typically, before I talk to you about 60 gray for a glioblastoma, in a situation like this, I would treat to 50 gray. A modest dose, providing them the survivorship benefit of radiotherapy, but limiting the risk of causing any injury in the area that we treat. At 50 gray, the risk of injury from radiation or the survivorship over decades is less than 1 to 2%. Lastly, and I think this is an area of ongoing investigation, I'm going to be speaking about it in the breakthrough session, is modality. So we have, Dr. Mehta mentioned various different modalities that we can use. The most common one that is used is intensity modulated radiotherapy. An area of ongoing research is whether proton therapy has any benefit by limiting dose. And so that's also something that we talk about. Oh, perfect. Thanks. This is an example of that patient who treated where the radiation dose profile for proton therapy is on the left, and the radiation dose profile for photon therapy or IMRT is on the right. And you can see we're treating the same iceberg with the higher dose, which is the sort of the orange-red area. But it's the lower dose, the blue and green with the scatter radiation dose. Does that have any clinical meaningfulness during the decades-long survivorship of these patients? I think that remains something that is under investigation, but it is something that I think about with my patients, again, trying to provide them the safest possible treatment.
Great, thank you so much. So in the interest of time, so that we have enough time for questions and answers, I think we'll stop the formal tumor board discussion here. But again, I want to thank the panel. What a fantastic discussion of these 2 patients. And I hope the folks who have been listening get an appreciation of the amount of expertise and thought that goes into decision making. So I will now turn it back to the ABTA and ask if they would provide us with the questions.
Thank you so much, Dr. Gilbert, and to all of our panelists for this wonderful and informative session. As a reminder, if you have questions that you want to ask, please type and submit it on the right-hand side of your screen. If you're on your laptop, just click the Ask a Question button, type and submit. If you're tuning in from the mobile app, please scroll down on the session for the questions section. We'll take as many questions as time allows. All right. So one of the first questions that we have here is asking, is there a limit to how much radiation a patient can receive in their lifetime? And Dr. Gilbert, if you don't mind, I'll address the questions to you, and if you can help identify who the appropriate panelist will be to answer.
Okay, this is an easy panelist, Dr. Gondi.
In the same area that we treat of the brain tissue, the more radiation dose that is delivered to that area is, I call it playing the percentages. It increases the percentage risk of causing radiation necrosis or injury in that area. So for instance, if Dr. Day were to do surgery in the motor cortex, there's a 100% chance of causing injury in the motor cortex and causing weakness on the other side. Radiation exposure to the motor cortex at certain doses have a less than 1 to 2% chance of causing injury to the motor cortex. But as you increase the amount of radiation dosed exposure to that area, the percent chance of developing injury rises. And at some point, it's a sigmoidal curve, so it starts rising exponentially. But another factor that is important when considering that, as I mentioned earlier, is time. Is the time interval. So if someone has received radiotherapy at one point and then many years later receives it again, during that time interval, the normal tissues forget their radiation exposure. And so that percent chance of injury goes down from that point.
Thank you so much for that answer, Dr. Gondi. Another question we have here is asking, can a low-grade IDH mutated astrocytoma become a glioblastoma later on?
So this is a great question for Dr. Horbinski.
The general rule is that these IDH mutated tumors will, over time, given enough time, they will progress to higher grade. And so, for example, you could have a grade 2 tumor that becomes a grade 3, as indicated by higher mitotic activity. And then if it acquires necrosis and or microvascular proliferation, we would call it grade 4. For whatever it's worth, we no longer call IDH mutated tumors glioblastoma. We use that term exclusively for the IDH wild type tumors that have the aforementioned histologic and molecular features that we had already discussed. Instead, we just call them astrocytoma IDH mutant WHO grade 4. And the reason for that is that in most cases, even when those tumors acquire grade 4 features, if you follow enough of those patients over time, they still have a longer median survival than IDH wild type glioblastoma patients. So we're really trying to kind of conceptually split the tumors apart. But yes, they can progress to grade 4.
Thank you so much, Dr. Horbinski. Another question we have here is asking, after a tumor board like the one you all just participated in, is a written transcript or report created that can be shared with the patient? And if so, how can a patient get access to that information?
So I'm going to ask Dr. Oberheim Bush what they do at the University of California, San Francisco.
So I think it's very different depending on where you are located in your tumor board. I can basically speak to what I do. And so the first thing is after tumor board discussion, I call the patient. So Thursday afternoons, I make a lot of phone calls because I personally call them and talk about the discussion. And so they can hear what we talked about and I can hear what they have been thinking about. And then I will create a note in Apex. It will either be at the bottom of my normal patient note or a separate note documenting the discussion and the recommendations. And in California, we have open notes, so the patients can see all of their medical records and can see that as well. So it's documented in the chart and they also get a phone call from me.
Great, thank you. Dr. Gondi.
Yeah, I'll speak on behalf of Craig at Northwestern. I think we don't have a formal document, but many of us do exactly what Dr. Oberheim Bush does, although I'm not as fast at calling people as she is. But yes, whoever's presenting the case, who's seen the patient, and sometimes there's multiple providers, one of them is the designated spokesperson to some extent to speak back to the patient. And then yes, document as a care conference discussion in Epic. and sort of be the spokesperson for the entire team.
Great, thank you. And finally, Dr. Day.
So we don't have a formal way where we document the whole thing in the chart. Usually, if it is a discussion ends in that the patient does need surgery, I do call those patients and I discuss the how we got to the decision of surgery and what the surgery would entail. However, if the discussion revolved more around needing more radiation or chemo, then it's the neuro-oncologist or the radiation oncologist who makes that phone call to the patient.
Great. And I can add that at the NIH, when we have our brain tumor board, since we often have colleagues participating from around the country, we have a formal report that goes out with a summarization of our recommendation. And so that is, I think, a smaller, a fewer number of patients, but often with very complicated diagnoses, both pathologically and often treatment history. So again, I think the important thing is that there is a record and that it's obviously used to really help guide patient care.
Thank you all for sharing how that works in your respective institutions. One of the cases that you discussed showed residual tumor or reoccurrence at a later time. Is there anything that can be done to catch residual tumor or reoccurrence earlier on?
So I'm going to turn that first to Dr. Horbinski and whether he sees a future for some type of molecular surveillance.
My knee-jerk answer is no, because I don't even like the term recurrent in the first place, to be perfectly candid. How can a tumor recur when it never really went anywhere? This tumor under the microscope on a basic molecular basis is infiltrating, it's crawling through the brain on a single cell basis. By the time we get these tumors, even at the time of original diagnosis, that tumor has spread far beyond what can be seen by the MRI. So this notion of trying to catch the tumor early before it recurs, I mean, really the day after surgery, by that metric, could count as recurrent tumor. I mean, that's the fundamental problem with this tumor and why its behavior is so unique relative to other tumors elsewhere in the body, the way it spreads. So I don't see there being any real, at least from my perspective, I don't see there being any real utility in trying to catch so-called recurrent disease earlier. I don't think that would have any meaningful effect on outcomes.
Right. Dr. Gondi, what do you see the landscape as far as, potential blood tests or things that might be possible to sort of give us a heads up that, to like Dr. Oberheim Bush mentioned before, sometimes you increase the rate of surveillance?
Yeah, I think it's a really interesting question and a great spin on it, Mark, in terms of thinking about where the future goes. Obviously, like Craig mentioned, it's about regrowth as opposed to recurrence. While it'd be great to have a blood-based assay, very similar to what we see in extracerebral cancers, meaning cancers outside the brain, like we're seeing this in lung cancer and breast cancer, versus PSA for prostate cancer. One of the natures that all of us know about the blood-brain barrier is that perhaps some of that cannot necessarily be extrapolated to what happens in the brain. Having said that, one of the advantages of brain tumors is the extent and quality of our imaging. And so where I do see a potential future is radiomics and the ability to use not just conventional MRIs, but much more advanced functional MR imaging, even years after a diagnosis and treatment, to be able to better predict or be more sensitive to capturing regrowth so it doesn't get to a point where, as it did in that individual, causes symptoms.
Great, thank you. And Dr. Oberheim Bush, I know that there's a fantastic imaging program at UCSF and doing advanced metabolic imaging, and your thoughts about that as a potential means to pick up tumor starting to grow early where we wouldn't necessarily see it on conventional imaging.
I think that's a great avenue that we're exploring to see if we can pick up changes in tumor earlier with metabolic imaging or specialized PET imaging, things like that. Not potentially ready for prime time yet and not widely available all over the country, but definitely an area to watch with a lot of really exciting research, I would say.
Great, thank you. And finally, Dr. Day, from a neurosurgical perspective, how do you see integrating? So if there's a potential blood test, if there's potential imaging, the role of the neurosurgeon in evaluating those modalities for early recognition of tumor regrowth.
So I would agree with everything that everyone said thus far. I think better imaging to first establish the extent of the tumor would be the first baseline. Like Dr. Horbinski said, how can you call it recurrence if the tumor initially never went away? We call it gross total resection because it is a gross, it's not a microscopic complete resection. It's what we could see based on the imaging modality we have. So that's why it's a gross total resection. We're not taking out every single cancer cell. We know, especially in terms of high-grade disease. So to have that initial baseline may be better. As surgeons, as I said, we're mostly limited by the functionality of the brain. So a lot of time we can see the tumor, we just can't take it out because it will leave deficit. But knowing that, creating that initial baseline, I think will be very helpful. And then afterwards follow up. And I think it will require multimodalities in terms of like integrating radiomics with some kind of blood test, maybe even CSF sampling, and having an integration of all of that data would be a better marker for predicting early recurrence.
Great, thank you.
That's wonderful. Thank you. I think we're going to squeeze in just one last question, and I'm going to use the term reoccurrence, even though we just talked about how that might not be the best term to use, but for sake of simplicity. This attendee is asking for a patient who has a low-grade tumor and has had a gross total resection. What are the chances of a reoccurrence happening?
It's a great question, and part of that risk stratification, I think goes into the tumor board discussion. So I'm going to get the entire panel on this. So the first question I'm going to ask related to this really important scenario is Dr. Day. And that is when you have a tumor that's declared as a gross total resection, what is your definition of that?
My definition of a gross total resection is when I look at the pre-op MRI and what my target is based on that. So if it's a high-grade lesion, it's the contrast enhancing part that I'm targeting to take out. If it's a low-grade lesion, it's the flare T2 signaling. That's the area I'm trying to take out. So as long as my post-op scan doesn't show any of the involved areas that was in the pre-op scan, I would call that as a gross total resection.
Okay, and so here, just for information, the timing of that post-operative scan is really critical, right? Correct. So you want to get that done in what time frame?
Usually I get them done within 24 hours and 48 hours and beyond that, we're pushing it because then we do start seeing post-operative changes, especially in terms of enhancement. So we definitely get it most of the time within 12 hours, if delayed within 24 hours.
Great. So that's really important because post-operative changes can emulate or simulate tumor, right? Because you see some inflammatory changes at the margin. So Dr. Horbinski, you're the pathologist. You get a tissue. The surgeon says this looked like a low-grade glioma. You look under the microscope, it's a low-grade glioma. Is there anything like margins in glioma like you have in other cancers? So when a breast cancer surgeon says, they took the tumor out and the pathologist says there were negative margins, does that apply in brain tumors?
it does not apply specifically in the context of diffusely infiltrative gliomas, which is mostly what we're talking about. It would be akin to the margins of a cloud. Either where does that cloud end or begin? It's really hard to say. So if I have a low-grade tumor, if I'm dealing with a tumor that looks fairly indolent, but is nonetheless by molecular a diffusely infiltrative tumor, meaning it's still IDH mutated, so on and so forth, it's going to come back in all likelihood, with only rare exceptions. It's just a matter of how long is it going to take before that thing manifests itself again clinically. However, we do know, in fact, that's one of the upsides of all this molecular diagnostics. We're starting to catch more and more cases that we thought were diffusely infiltrative tumors, but by molecular are pointing towards, no, wait a minute, this is actually not. This is a what we call a circumscribed glioma, meaning even if it doesn't look clear cut on histology, the molecular indicates that actually this thing has probably been there for a very, very long time, is really not doing a whole lot in terms of migration or anything. And in many of those cases, when we follow those patients up for years and years and years later, there's no recurrences, there's no progression, there's no nothing. So, the term low grade can mean two things. It can either mean a more protracted disease course, or in some cases, that's pretty much it. And obviously, we like the latter case as much as we can, but that's just the great thing about molecular, because I have gotten a lot of cases over the years, even just over the past month, consult cases from the outside that were called something much worse than they actually ended up being by molecular.
Fantastic. And
That's
so,
great. I'm sorry, Dr. Gilbert, but in the interest of time, unfortunately, that is all the time that we have. So I apologize, Dr. Gondi and Dr. Oberheim Bush, that you weren't able to answer this question, but we will try to respond to some of the Q&A on HUVA at a later time. At this time, I'm going to go ahead and turn it back to Emily for the rest of the program.
Yes, thank you so much, Brain Tumor Board panelists. We really appreciate each of you contributing for today's panel. That is such a dynamic session, and we know our attendees really appreciated it. As Breen stated, we will try to respond to some of those questions unaddressed and share at a later date.